I'm Dr. Chuah Huat from Gastro-enteric Unit, Department of Medicine and Faculty of Medicine. So I'm the moderator for the second session. Before we start, let me introduce our distinguished speaker. Dr. Stanley is currently a consultant gastroenterologist and hepatologist at the University of Malaya Medical Center. He is also a visiting consultant for the endoscopy unit at the University Putra Malaysia Teaching Hospital and Hospital Kuala Lumpur. His main interest includes endoscopic ultrasound, or what we call as EUS, and pancreatic biliary diseases. Having completed his fellowship in endoscopic ultrasound at the Center of Excellence in GI Endoscopy, King Chulalongkorn Memorial Hospital, Thailand. Of course, he is one of the pioneers in starting the endoscopic ultrasound-guided biliary drainage in Malaysia. And he's one of the best endoscopists and gastroenterologists in Malaysia. In terms of administrative position, he's also very well established. He's currently the executive committee member of our Malaysian Society of Gastroenterology and Hepatology. And he's also a member of the prestigious Asian EUS group. He's also our co-course director for our annual National Endoscopic Conference, our Endoscopy 2024. Dr. Stanley has published numerous research articles in many international peer-reviewed journals. Today, we are fortunate to have Dr. Stanley Khoo to share with us the presentation with the title, Therapeutic Endoscopic Ultrasound, Beyond Boundaries. Dr. Stanley, over to you.
Thank you, Dr. Chuah, for the kind introduction. So I have a lot to unpack, trying to squeeze as many procedures as possible to talking about interventional endoscopic ultrasound. So I'll just fly through the slides and then we can discuss if there's any extra time. All right, let's see. Okay, so EUS existed first in the 80s, now mainly as a diagnostic tool. Now, as the name suggests, you know that this is an endoscopic procedure that goes into the GI tract and visualized with an ultrasound probe all the surrounding organs, mainly the liver, the bile ducts, the vessels, the pancreas, etc., etc. Now, it also able to take biopsies in terms of tumors and cancers. But in recent times, I think in the early, maybe about late 2010s, it has been increasingly expanded into the therapeutic aspect of in this endoscopy. So basically what we can see, we can certainly do something about it. So this is how it looks like and how you do an endoscopic ultrasound, where there's the tower there with the scope, just like any endoscopic procedure, and an ultrasound screen to look at all these surrounding structures. Now, these are all the therapeutic possibilities that are available at this moment, and you may or may not know. I'm gonna go through it all of it in a very short snippets of it. Mainly celiac plexus neurolysis, radiofrequency ablation of tumors, pancreatic cirrhosis drainage, biliary drainage, gallbladder drainage, gastrojejunostomies or gastroenterostomy bypass, and vascular interventions, including measuring the portal vein venous pressure, as well as coiling embolization of gastric varices. So when we talk about CPN, essentially we are able to see the celiac plexus surrounding the celiac axis structure. These nerves are very important in innervating the various structures surrounding the area, mainly the pancreas. So when we are able to see the veins, we are able to inject anesthetic agents such as bupivacaine and alcohol to completely obliterate the nerves. This would decrease the pain perception when it comes to pain relief. This is exceptionally useful for pancreatic cancer patients, whereby instead of using oral morphine, EUS CPN has shown to have as much as a 30% improvement when it comes to pain relief in advanced pancreatic cancer. Next, we're going to talk about EUS radiofrequency ablation. This means burning off the tumors. So essentially, RFA is not something new. We have RFA many places, including liver tumors. So this has extended into pancreatic cancers as well. So pancreatic cancers with the heated probe, you are able to obliterate cancer tumors without going through surgery. So this has been proven to be very effective, especially in conditions such as pancreatic NET, where a major surgery may not be so warranted or such an overkill. Just to show that this is one of a patient with the pancreatic NET at the head of pancreas, and this is how the EUS RFA looks like when you can see the tumor over here at the hypoechoic region. And then when we put in the probe, you can see we start burning through the lesion. And you can see it whites out the whole lesion, and then we can obliterate the tumor there and then. So the tumor get resolved. Next, we talk about pancreatic fluid collection drainage or pseudocysts. Now, EUS has been the mainstay in therapy in draining pancreatic fluid collection. Pancreatic fluid collection is as a result of is a common complication of pancreatitis. So there are various stages of pseudocyst correction, and for only these two pancreatic pseudocysts or wall of necrosis where we need to drain. Traditionally, this has been drained either radiologically or surgically. But EUS has been the mainstay in drainage in this various indication because it is minimally invasive, efficacious, better outcomes, and less complications. Now, this is how it looks like when you see the cyst over here in the pancreas. All you need to do is just to place a fistula stent draining from the cyst into the gastric region without any drainage catheters or any major surgical intervention. Now, ES approach has been proven to be cost-effective as well as more efficacious in studies, as well as comparing to radiological drainage and surgical drainage. There has obviously a better outcome and lower adverse events and shorter mortality rate. With the invention of specialized stents, fistulating stents, this has made the procedure much more easier to perform and in very quick succession. Usually takes about 5 to 10 minutes and you can finish the procedure rather straight away. So this is an example of how it looks like. You can see there's a pseudocyst over here. And when we burn through the stent, you can see we're just releasing the stent. And the stent will straight away release into the stomach, and you can see a lot of fluid draining out from the stomach. You can see the stent is over there. Stent is inside the cyst, and stent is outside the cyst. So it provides a communication between the cyst and the gastric region for continuous drainage. So in case of an infected pseudocyst, where you can see a lot of infected materials or necrotic materials inside, is the same thing. We provide a gateway into the cyst itself, deploying the cyst, draining out the cyst. You can see in this patient, after dilating the cyst, you can see a lot of pus being drained out, and we put a stent, and we can access into the cyst to try to clean out all the debris. So you can see all the debris here in the cyst. We can try to go in and clean up all this dirty infected debris without surgery. Again, this is an endoscopic procedure, and at the end of it, you can see that the cyst will be very much cleaned out like this. All right. So from a dirty cyst, you can become a clean cyst based on just endoscopic procedures. Next, we talk about biliary drainage. Now, biliary drainage has been a mainstay in therapy for biliary obstruction in malignant diseases. We have used ERCP as the mainstay therapy for the last 20 or 30 years. And for those who cannot do ERCP, and people have been using PTBD. So the indication for EUS bile duct drainage is if they cannot do ERCP or they have altered anatomy, and it can use both in malignant and biliary, and both benign and malignant obstruction. Now, the problems with the current method is ERCP is there's a risk of pancreatitis, and sometimes the procedure is very difficult to perform in cancer patients. And the problems with PTBD is they have recurrent cholangitis, electrolyte loss, a lot of discomfort, a lot of pain, a lot of adverse events such as tube dislodgement or infection, and the higher rates of blockage and reintervention. So this helps to bridge the gap with USBD, whereby it results in internal drainage, lower rates of biliary obstruction, and it can use in patients with altered anatomy, and there's little to no risk of pancreatitis. So if you look at ERCP, this is what we do conventionally. We try to drain the bile duct endoscopically through the ampulla ovata or papilla. So this is sometimes not always possible when there's a tumor growing around this area. So when that doesn't happen, this results in internal drainage. When that doesn't happen, people do PTBD. If you look at PTBD, it's an external drainage where you can see the patient has a tube with it, and these tubes can get dislodged, a lot of discomfort. Patients don't like it, and there's a lot of pain. So this results in external drainage, which is not very ideal. So much so that EUS guideline has been established in major guidelines whereby it is recommended to do EUSBD and ERCP over PTBD because of all these reasons. So what are the techniques of EUS guided drainage, bile duct drainage is possible? So these are the 4 techniques, but mainly we're going to talk about hepaticogastrostomy, means draining from the liver into the stomach, or choledochoduodenostomy, means draining from the bile duct CBD into the duodenum. So this is how the pictorial illustration looks like. Basically, you just want to create a fistula between the bile duct, an artificial fistula between the duodenum and the bile duct. And for the hepaticogastrostomy, again, it's the same between the gastric and the intrahepatic ducts in the liver, where you place the stent across. So I've created an algorithm and guidelines involving ERCP as well as EUSBD when it comes to malignant biliary obstruction, which does not involve PTBD. Now, again, like I say, with all these stents, this has made the procedure a lot easier. I won't go through these specialized stents. So for choledochoduodenostomy, you can see that on EUS, we can see a dilated bile duct system. We can straight away just puncture straight into the bile duct. You can see this is the bile duct, and we can place the stent straight away across very quickly, about in a very short time. And you can see this is an artificial drainage of that. Now, with the using of a lumen opposing stent, this is make the procedure even shorter. This is a bile duct. We just put in the lumen opposing stent into it, and we release the stent into the duodenum. You can see that the bile straight away drain between the bile duct as well as into the duodenum straight without going through the ampulla oblator. So EUS-HGS is very useful when it comes to altered anatomy where the papilla is not accessible. So this is a patient with dilated biliary system from recurrent pancreatic cancer post-surgery. So you cannot do an ERCP in this patient. So what you do is you can just directly inject, puncture the intrahepatic ducts. You opacify the intrahepatic ducts, and you place a stent across the intrahepatic duct straight away into the stomach, and you release it into the gastric part of the stent. So you can see bile is flowing out very nicely in the gastric region, and from the endoscopic procedure view, you can see the stent sticking out from the stomach, connecting the liver into it. This is how it looks like on a CT scan for another patient. You can see the stent communicating between the intrahepatic ducts and the stomach. So it drains directly internally without the use of an external tube. You can also combine it with ERCP, where in the case of an hilar obstruction, we can do ERCP here to stent the right side of the duct, and we can do a EUS hepaticogastrostomy on the left side of the duct to result in complete drainage in both the right and left intrahepatic ducts. And this has been shown to be very efficacious with over 80% to 900% of success rate in published studies. And best of all, most of the studies shows that EUSBD is superior to PTBD when it comes to clinical efficacy as well as lower rates of adverse events, whereby PTBD has about almost 50% adverse events. Hence, we shouldn't be doing PTBD when it's not indicated. So we have published our own data about 4 years back actually, which shows that about almost 90% success rate and about 6% of complication when it comes to our first few cases. So in conclusion, EUS biliary drainage should be the recommended biliary drainage method if ERCP is not possible and not PTBD. As a lot of all these problems have been overcome when it's faced by PTBD, and it's really recommended in all major guidelines. Next, we talk about gallbladder drainage. So it's the same thing. Endoscopic EUS guided gallbladder drainage is useful for patients who have acute cholecystitis who are not surgical candidate to resect the gallbladder. So essentially, if you drain the gallbladder nicely, you are able to drain all the infection away from the gallbladder. So this has derived, with this concept, you can see that we can create the similar concept of creating a fistula between the duodenum or the gastric region straight into the gallbladder, draining all the pus or infection through without the need for surgery. And this has been proven to be as effective as laparoscopic cholecystectomy when it comes to patients who are not a candidate for surgery. But yet, this can also be useful in patients with malignant biliary obstruction, where you can drain the bile duct since the gallbladder and the biliary system is connected. Whichever way you drain, you should be able to drain all the bile accordingly. So, in patients with malignant biliary obstruction, one or the other methods, other than the one that I mentioned before, you can also use gallbladder drainage to achieve a good success when it comes to draining the bile duct biliary system. So I have a patient with a pancreatic cancer, again with biliary obstruction of due to the pancreatic cancer. And you can see there's also a mildly dilated common bile duct as well as a very dilated gallbladder. So when you can see a gallbladder, you can just straight away drain it, just like how we drain most of the cysts. We put in the stent, just like how it is. And then we release it into the GI cavity, in this case in the gastric. So you can see a lot of bile being drained out from here. Okay, so you can see the stent is well within the gallbladder. And post-procedure, when the bilirubin is about 300 over, about 2 or 3 weeks post-procedure, the bilirubin levels has dropped to almost in the normal level. Unfortunately, the patient succumbed to the disease itself, but at least they didn't pass away with jaundice or pruritus. Next, we talk about gastro-enterostomy or gastro small bowel bypass. Now, gastric outlet obstruction is a very common complication when it comes to gastric cancers or duodenal cancers, etc., whereby patients will vomit and then unable to tolerate orally. So traditionally, people either place transluminal stents or do a surgical bypass, whereby they bypass the obstruction and the oral intake should improve. But there are a lot of problems over here. So when it comes to surgical gastroenterostomies, there are a lot of problems such as bleeding or failure to anastomosis or wound breakdown or anastomosis breakdown and prolonged surgery and morbidity surrounding surgery. Whereas transluminal stent, there's always a risk of tumor overgrowth or tumor growing into the stent, causing recurrent stent obstruction and gastric outlet obstruction. So to bypass all these problems, using EUS, we are able to see the small bowel in close proximity and again create a fistula, create an artificial bypass on or sort of like a pseudo-surgical bypass in a much more non-invasive way, in a non-surgical way. And this has been proven to have better outcomes, lesser recurrent GOO, better oral intake, as well as better quality of life. So I have a patient here with an advanced ovarian tumor with lymph node metastasis, tumor so huge that it's causing both biliary obstruction as well as a gastric outlet obstruction. So if you look at the CT scan over here, you can see there's a large tumor over here surrounding with a very dilated stomach and biliary obstruction. So we're going to do a gastrojejunostomy bypass EUS guided as well as a biliary drainage at the same time, all in the same setting, tackling two problems all at the same time. So the basis of it is you're trying to infuse the small bowel with a lot of water reservoir. And once you are able to do that, you can create a fluid-filled sac in a small bowel, and you straight away create a fistula between the small bowel and the stomach, resulting in a complete bypass away from the tumor. So EUS, it looks like that. So first we put in the nasogastric tube into the small bowel to try to infuse as much fluid as you can. And from the video, you can see here, we can see this is the small bowel, and this is the tube within the small bowel. So after that, you just need to put a stent across and release it into the stomach. All right. So you can see this is the gastric side of it. And you can see contrast flowing into the small bowel nicely from the gastric into the small bowel. So at the same time, then you can straight away do a hepaticogastrostomy for biliary obstruction. So this is how it looks like on the endoscopic side of it. So you can straight away do a hepaticogastrostomy. So this is a dilated intrahepatic ducts in the liver, on the left side of the liver. Once you puncture the duct, you were able to cannulate and light up the intrahepatic ducts over here. And once you are able to create that track, you can straight away place a stent across the hepaticogastrostomy stent. So this is the hepaticogastrostomy stent coming out at the stomach, and then this is the gastrojejunostomy stent, all in the same setting. So the stent will look like that. This is the HGS stent over here, and then this is the gastrojejunostomy bypass. So the patient was able to resume complete oral intake about second day after the procedure, and it was discharged 3 days after that. A lot of lesser surgical morbidity, and 2 weeks after the procedure, the LFT, the liver function has normalized, and the oral intake is very good. So for those who are interested, this is how it looks like for another patient about how gastrojejunostomy bypass look like. So this is the stomach. We put in by the scope. You can see that this is the lumen opposing stent creating straight, gives you direct access into the small bowel. So going in, and you are able to see straight away the jejunum over here, which results in a complete bypass away from the pylorus on the tumor across the area. So this is very helpful in patients who have gastric outlet obstruction. Next, we're going to talk about gastric varices. Esophageal varices or gastric varices are a complication of portal hypertension for liver cirrhosis where they present with hematemesis. And endoscopic gluing has always been the way of doing it, but however, there's a lot of problems, including pain, embolism, and the problem is not able to visualize the varices in real time or targeting precisely. So EUS helps to bridge that gap by able to see the varices completely. Now, this principle was derived by all the vascular embolization of all, for example, aneurysms or bleeding, etc., where you put coils into the vessels and you are able to cause anticoagulation and vascular stasis, and hence cessation or hemostasis or stopping of bleeding. So gastric varices of using EUS has been far more superior compared to endoscopic direct treatment of gastric varices. So this is how it looks like when you see a lot of gastric varices surrounding the stomach. You are able to do EUS and visualize all these targeted vessels, and you can do very targeted therapy, and you embolize all these varices, and by doing so, it straight away stops the problem, and the patient will not have bleeding from gastric varices. So this is how it looks like. This is a gastric fundal varix of a patient with a very large varix over here. So on EUS, you should be able to see the varices over here. And once we injected that, we can put coils into it. So you can see there are coils coming out from here. I'm just seeing. All right. So you can see that these are coils over here. All right. Once look at that. This circular artifact is the coil that's being inserted directly into the vessel without the which is much more targeted therapy. And then injecting glue as an adjunct to try to scaffold the varices. After that, you put on the Doppler flow, and then you don't see any more flow within the gastric varices. So on endoscopic view, you would see that this is a bloodless procedure, and you can see that the gastric varices have decreased in size, and the patient doesn't have any more recurrent bleeding from there. So you can see that this is the X-ray view of how the coils go in. So in summary, that this is much more effective compared to endoscopic glue injection. Lastly, I'm going to talk about portal pressure measurement. So measuring of portal hypertension or the objective measurement of the portal systemic pressure is very important because it is one of the critical complications of liver cirrhosis, leading to all the complications resulting from portal hypertension, such as bleeding, varices, etc. Now, traditionally, this is a vascular intervention whereby you need to innervate the hepatic vein and the portal vein to try to read the vessels of the hepatic and the portal pressure to ascertain the portal pressure gradient. But however, this is not easily available, and a lot of people don't do this, and the readings are very variable and inconsistent. Now, that's when EUS comes into play, where EUS, we are able to visualize all these vessels directly without going through the long route. We can directly inject or puncture straight away the vessels to be able to connect it to a barrel device, and we are able to read the pressure almost immediately and directly, and it's provided to have very consistent results. This is because on EUS, we are able to see all the vascular structures of the liver, including all the veins, hepatic veins, and the portal vein very clearly in real time. So this has been shown in all the studies, started off as an animal experiment and then all the way up to the human studies, where it correlates very well with the existing method of using the traditional vascular measurement of portal systemic pressure. So this is how it looks like. This is a patient with cirrhosis. Once we see this is the part of the left hepatic vein, we just have to puncture that. All right, let me see. Oops, think something wrong with that. Let's try that again. Okay, I think something wrong with my PowerPoint. So essentially, we are able to measure the portal systemic pressure straight out of it. And okay. But I don't think I'm able to load that slide again. Okay, just give me another minute. Okay, I'm back. That's actually the final slide already, so we still have a lot of time actually. Okay. Okay, so we are able to see the vein. Once we puncture the vein, you are able to directly detect the backward pressure from the left hepatic vein into the barrel device. So you can see this is how the barrel device look like. And the numerical pressure will be recorded over here, and we take the average reading of the pressure. The average reading of the hepatic vein pressure usually ranges to about 5 to 10 millimeters mercury. And then from here, we can straight away. Okay, it's not working again. So I'm not going to play the video again because it has caused my PowerPoint to crash. So in other words, we are able to measure the portal pressure as well as the venous pressure to able to know the average portal pressure, portal systemic pressure. This is very essential to able to predict the severity of portal hypertension and also to target our treatment of beta blockers when it comes to reducing portal venous pressure in patients with liver cirrhosis. Just like how you measure blood pressure, you give antihypertensives, you want to have an objective guideline on how to reduce the pressure. So with that, I have only one last slide to show that okay. I won't show the video again. So with my final slide, essentially, there's so many things to do using EUS and has expanded a lot of non-surgical therapies as much before than we have never seen. And this has enabled a lot of non-invasive possibilities when it comes to treatment of GI, liver, and even vascular interventions when it comes to all these diseases. And EUS has made this possible over the last 10 years. Now, essentially, all those has proven to be less invasive, minimally invasive, in fact. They have a lot of better outcomes and, more importantly, lower complications than existing method. So with that, I thank you, and I'll take any questions from there.
Okay. Thank you very much, Dr. Stanley, for a comprehensive talk about advanced intervention EUS. As you can see, EUS has progressed very far from as simple as assessing the pancreatic and biliary lesion, which is very difficult to be assessed by conventional manner, until up to the advanced intervention whereby, minimal invasive, biliary drainage, gastro-jejunal stomy bypass, then pseudocyst management, and even varices and portal hypertension management. Very nice demonstration by Dr. Stanley. So in the Q&A box, we can see one question for Dr. Stanley. The pancreatic drainage stent, do they need to be removed? And will fistula formation be an issue in the long term? I guess, Dr. Stanley, can you answer that?
Yeah, so by and large, pancreatic stents are not that permanent. As long as the underlying pathology is being resolved, then there's no risk of recurrent pancreatic fluid collection. You can just remove the stent and the fistula will close automatically in most of the cases. But in any fact, if there's a long-term fistula formation in very unlikely few less number of cases, actually it's not a problem, any issue when it comes to these fistulas, because these fistulas are usually very small, and like I say, most of the time they close spontaneously and they recover without any complications.
Right. Thank you, Dr. Stanley. Any other question from the floor? Otherwise, can I just ask one last question to Dr. Stanley?
Okay.
So, Stanley, as you can see, ERCP in the past has progressed very far. Initially ERCP was a difficult procedure. Hardly anyone able to do it. Our late Professor Go has to go all the way to Netherlands to learn it and pass it down to many gastroenterologists and hepatobiliary surgeons. So in EUS, as you can see at the moment, still not many people. I mean, EUS, most of us are doing, and many of us are doing it. And at once EUS, when do you think that it will come to the phase whereby EUS can be as popular as ERCP procedures?
Well, again, there are many factors. The long and short of it is people have to be aware of such procedures, and they have to be educated about the benefits of this least invasive procedures that is being done. And of course, like how ERCP was, it's going to take quite a number of years for this to go on. Facilities has to be expanded, training has to be expanded in order for this to propagate in the future, like most other routine endoscopic procedures. So I don't know what's the timeline, but of course, there's increasingly more and more people are interested in doing this. And in Malaysia, I think few years back only started off with me doing it, and then I think over the years some other hospitals I've managed to have the privilege to help to establish all these services has been going on their own, and so I'm cautiously optimistic that this procedure will probably be mainstream in probably about many years to come in the future. Yeah.
Right. Thank you very much, Dr. Stanley. In view of the time, I guess we have to close this session. And I would like to thank everyone for your presence and your kind attention. Thank you very much again, Dr. Stanley, for your comprehensive presentation. And thank you to the department and also faculty for providing this platform for us to share, as well as thank you, everyone, and have a good day.
All right. Thank you. See you guys.